the target and hit anything in the collimator can destroy the skin sparing effect of the treatment, because remember, it has to be at least 12 centimeters or 15 centimeters above. Anything that's in the head has to be 15 centimeters above the patient. If it's not, then the electron contamination can destroy the skin sparing effect. And what's the skin sparing effect? What's skin sparing? Come on, guys. What's skin sparing? Where's D-max on a 6FB machine?
1.5 centimeters.
So that is skin sparing. Therefore, your 100% of your dose doesn't go to the edge of your skin. It goes below. That is what they call skin sparing. So what happens is, if you have something too close to your skin or the patient's skin, it can destroy that. It can give an added dose to the skin, the surface of the skin. Does that make it a little bit clearer? Okay, so we've done that. Okay. TD we've done. Breast bridge. So I was trying to explain what a breast bridge was. And there's your breast bridge. And basically what it was is two pieces of perspex, and these open up so they can fit the patient. And there's a level, or there was a spirit level across here. There it is there. And you have to get the patient level at 90 degrees so that you can actually use these. And what they used to do is keep the breast to a certain extent in position, and also you could put bolus inside there so that it would build up the dose. That's a breast bridge. Okay, next. Okay, so we're talking about the SRS frame. The SRS frame isn't the halo thing that you screw into the skull, although some people call it that, but this is the SRS frame. It's not a very good photograph, unfortunately, but let me put the lights off and you can actually see it properly. So the actual frame that is, this is the actual frame. So this has what they call on here. What do you call things that are on the skin that can be shown up on the imagers? Fiducials, that is correct. So each of these bars have little fiducials inside them. So you can actually see them on the imager, and you can actually, the surgeon and the oncologist can actually see those on either the MRI or the CT and make sure that they're going to be treating in exactly the same position, or they want to. Okay. Thyroid notch, we had a problem with where the thyroid notch was, right? Where is the thyroid notch? There's a better way to put it. Okay, so here is, just make that a little bigger. There. Okay. So here is the thyroid, there's the epiglottis. Here's my, here we go.
It's touch screen.
There's your epiglottis. This is the hyoid bone. There's your thyroid notch here. This is your thyroid lamina, and here is the cricothyroid ligament, and the trachea is way down here. So there's the cricoid cartilage. This is cartilage, this is not bone, by the way, guys, this is bone. So this is cartilage. So there's the cricoid, and there's the thyroid and the thyroid notch. So it's here. This is the cric. So it's about here somewhere. Okay? I'll send you all these things. So, anywho. So a few more things. I was being asked by several people, when can they apply for the registry? You can apply for the registry 3 months before you graduate. You graduate officially on the 3rd of May. That's when classes finish. That's when you'll have the results of your exam, your final exam here, okay? And that's the day you graduate. So you can apply for the registry, we'll say the 4th of February, which is next Friday. I'll give you some information on that so you can do it, and it's online now. So I'll give you the information and you can go ahead and do it. But you cannot actually sit the exam until 3 months after you pass, after you finish with the exam. Okay?
Wait,
what? 3 months after you graduate?
You cannot, well, excuse me, no.
3 months after you
I'm sorry,
register.
you can.
Right.
You can actually graduate, you can actually sit the exam. If we finish on the 3rd, you can do it on the 4th. Sorry, it's Friday morning, what did I say? Yeah, so you can actually sit the exam on the 4th of May. If you're lucky enough to get a exam date on that day. So what normally happens is you apply through the RTT. They look at your application form, it comes to me. I make sure that everything is correct as far as dates and stuff are concerned. I sign it and send it back, and everything of course is now done electronically, so it'll be a lot faster. So I send it back, and then they look at it, make sure everything is good, and they will then send you a letter. And I believe it's still sent snail mail, still sent actually through the mail. What you will get on that letter is you will get a examination number. Then you apply, or you call, or go onto the website of Perkins View and request a date for your exam. Now, Perkins View just don't do radiation therapy, they do all sorts of engineering and everything, any kind of exam. They will give you a date. If you say you want to go to Jacksonville, do the thing in Jacksonville, then they'll give you a date and a time for that particular site. As far as I'm aware, there is only one Perkins View site in Jacksonville, and that's somewhere in Bay Meadows, somewhere, I believe. But there are sites elsewhere. I remember a couple of people, a couple of years ago, going to Savannah, to take their exam. In Orlando and various other places. So it's best, if you're going to do it soon, my recommendation would be that you do it as soon as possible after you graduate, so you don't forget things. But that's basically what I would suggest you do. The other thing for those people who've missed the last little while is the pinning ceremony is on May 5th, and that's at Kent campus. The commencement, which is your actual graduation with the cap and gown and all that lovely stuff, is on the 12th at Veterans Memorial Arena. And they both start at 4 o'clock. So for the pinning, I would suggest you be there by about 3:15, 3:30 at the latest, so we can get you all organized and everything before it starts. And the commencement, I believe they need you there for 2 o'clock. So you can bring family and friends, if you like, to both. For commencement, I'm not sure if they give you so many tickets for family and friends, I'm not sure. But as far as pinning concerned, we have a very large auditorium and we're pinning with radiography. So you can probably bring several family members if you so desire. Questions on those? Yes, ma'am.
If we're not gonna be here.
Okay,
For pinning?
for pinning, yes. You can still get your pin.
Okay. We're buying our own pins, so.
There is actually, I just got
We have to buy our own.
pin order forms. Did everybody see the pin? I put it up, I'll show you later. There are order forms here. The deadline to order is the 4th of March, so that they actually get there, you actually have them on time. The price includes, and you get them from the bookstore, you order them from the bookstore. The price includes engraving of up to 3 initials on the back, and also the year. And there's gold plated, silver plated, sterling silver, single gold fill, double gold fill, 10 karat gold, and if you really want to know, 14 karat gold.
How much are they?
You really want to know?
Those are the
Yeah.
most
Okay.
expensive ones.
So-
So what is
The
it? What?
gold plated ones
Cheap.
are $38.25.
Wait.
$38.
Oh, okay. Here I'm like 3,000.
Silver plated
Fucked up. Like,
$38.25 as well.
all right, that's not bad.
Sterling silver is $65.50.
Okay.
You want me to go on?
Yeah.
Yeah, I want to know the most expensive ones, to be honest.
And none of them are over a
Single
grand?
gold fill is $125.50.
Okay, that's okay.
Double gold fill
Good.
is $117.90. Here comes the biggies.
Yeah, I
10
want these
karat gold
ones.
is
I want to know these ones.
$687.30.
Oh my god.
So why do people get these?
And the 14 karat gold is $1,014.55.
Like, I don't care what it's made of, they all look the same.
Do they all
Yeah,
look the
pretty
same?
close. So,
Yes.
I know that some people
What do they look like?
got sterling silver, last
I would do
time.
sterling silver.
but the gold plated, silver plated, you know, as you see, they all look.
Can we see what they look like?
Huh?
Can we see what they look like?
Oh, yeah, let me see if I can find them now. Hang on a minute. I think they're in here.
I'm gonna get a bagel while she's doing that. Do you want one? Do you want one, Morgan?
There's everything. There's
It's a
plain.
memory.
There's
Did you get a high
coffee.
school ring?
There's
No.
Okay.
Because I don't
Seattle.
care about
There's
stuff. I'm not
blueberry.
sentimental.
There's
Okay.
I have a
Sesame.
CD
I'll look
pin.
for it over
There's-
the.
I didn't have
over the
paper.
break
There's
and,
everything.
And they
Well,
let you go
seriously,
look.
she said that you can, it's ordered from the bookstore, so if you still have your voucher,
That's what I was thinking of.
you can use it.
Oh, that's nice. I never got that. I didn't know how to do it. And I think I had like $10 left.
Hey, those,
Oh, you
so
can
you can upgrade.
You could use them both ways.
Oh, how do you use it online? I tried
How
figuring
do you
out.
use it? There's a spot that says.
Oh, is this the poppy seed?
There's a spot that like says if you're using, not a
Oh.
credit card, but like a
There
credit
is.
card or a voucher or something.
There's your pen, guys.
Oh, that's big.
That is cute.
So the actual size is 0.875 of an inch, so it's about that size.
Something can cost $1,000 at that size.
So it's not
Well,
bad.
I guess earrings and rings and shit, but like,
There's
no
no
diamonds.
no, there's no diamonds in it. So it's
Say again, I'm
Our
sorry.
last week of clinic.
The last week of clinic,
25th. It would be the last.
yeah, about the 26th of April. Yeah.
Put it on my calendar.
Yeah.
So you're like.
Well, then I got
I'm in
Okay,
CT.
so,
That's us.
Where?
CT
Oh.
at Gainesville. The people are cool.
Yeah.
I like them. But Phil was like, we have an HT something, a student from down south.
Oh,
Florida.
HTC. Yeah.
HTC, yeah.
oh, my goodness. Send them in if I take one home.
No, I got 12.
When did you
and
say
I know that we
last-
don't have 12.
Last clinical is?
The 26th, April 26th.
25th.
It's the week of the 25th,
So,
whatever.
so we go through the 28th, which is
That's
Thursday.
correct, yeah.
Okay, so the 28th would be the last.
So probably the last, we'll
Last
probably do the exam on the Friday,
The Friday
28th.
before, or?
You mean the
the-
29th?
Okay.
20, whatever it is,
Perfect.
28th.
How's Amanda doing? Are you seeing her?
Okay,
Amanda.
so,
Really tired.
once you guys, so
Skinny.
would you like
She had back
these,
surgery. She's fine. She's good.
would you like these forms now, or do you wanna wait till next week?
She had back
What is
surgery.
it? The pin form?
No,
I was like, I know the name.
she had two of her
Having fun with
liver refused.
Oh, and you're on?
Okay, I think I've got
She's
it.
not back
organized.
organized. Yeah, she's not back to 100%, but she's
She's
there.
good, that's all. What do they have her doing?
Oh,
Thank you.
So you don't
I
get.
don't know.
I'm saying, is she still heading back?
Oh.
Yeah, I think so.
Oh.
Cause like, right before she.
So obviously it's the first
Her on one.
one, first.
Oh. Okay.
Yeah.
Oh, I could have paused this.
There you go, ladies. The gown on, so nobody really knows what you have underneath. But for pinning, I would like you to have, to be in dress clothes. Either a dress or a nice a blouse and pants or something like that. Heels if you want to wear them, I certainly won't be wearing heels, but whatever you feel dressed in. But what I was telling the other ladies
We'll coordinate.
last week was that
We should all match. We're the same exact.
I've seen one person come to pinning in jeans and a t-shirt.
Oh no.
Luckily enough, it wasn't my class, because I would have sent them home to get dressed. But there was one group, and there was two girls, both of whom were, should we say, rather what my mother would call well endowed. And
Not
one of
me.
them had spaghetti
Not I.
straps on, a top, and the other one had basically
My long hair. I'm alive.
that basically was a
A
strapless top.
That's cute.
So
Yeah, but where do you put the pin?
the problem is
On her
where you
boobs.
put the pin.
On her
Luckily
nipple.
enough, it was a female member of staff who was pinning them, not the male member of staff.
Poke the nipple.
So they were, she couldn't get the pin in without, no, so, anyway.
Putting her hand underneath and
Yeah, well, that's something that we don't want to do. So if you guys want to coordinate, that's fine. If you
Guys, let's all
don't worry
come
about
shop
it,
in wedding
but please,
dresses.
please don't turn up in something that makes you look as if you're on the local stroll.
We're all gonna wear boob tubes. Boob tube, boob tube.
What about wedding dresses? Let's all just pull up in like wedding dresses.
Okay, so let's
Let me
start what we were doing.
I don't fit in
guys.
mine, so.
Oh, shit. I didn't even have one.
Okay. So, this is a continuation. What we're gonna do for the first couple of weeks is just go through, the website of the follow, of the, Mosby book. This is the,
Thanks.
Sick, bro.
radiation therapy treatment. So, can everybody see that from the back?
No. That's better.
Actually, I can't, because
That's okay. When I can get
I
it
have
on
to.
my,
No, I can actually, it's okay, I can. Oh, sorry, oh wait. I can, as long as I can see, submit, that's good. Okay, when the actual dose delivered needs to be verified in vivo, dosimetry can be established by using what? Now we have to figure out what in vivo means. What does in vivo mean?
Live,
Live. So what would that
It
mean?
is.
like live in action,
Yeah, so,
like a patient's on the table and you're
right,
giving.
that's
them
what I
dose.
wanted to hear, yeah, the patient's on the table, yeah.
That's good.
So what's the opposite? What does in vitro mean?
Petri dish.
Yeah, in a lab usually, yeah. So in vivo means you're doing it on a real person, in vitro means you're doing it in a lab. Okay, so what actual dose delivered needs to be verified in vivo dosimetry can be accomplished by using what? You're looking for dosimetry. Which of the four would you want to look at or want to use?
B and C.
B? Bravo?
Well, is it TLD?
Any advance on that?
Is that the thing that you have to send out to the lab?
I say B. B? Bravo?
I think so.
I don't know.
I think it's a TLD.
So,
I've seen physics book.
B? Everybody agree?
I go with D.
D? Delta?
I've never heard of it.
Okay, so I have B and I have D.
What is the
Why?
thing?
Huh?
That's the thing that we.
None of the above look familiar to me, so.
What
The
is
GM, yeah, C is, but
the,
you're not in the room.
No.
When you're giving it.
So
B, the thing that we use, that we attach to
None
a
of the above look familiar
diode?
to me.
Is that considered a dosimeter?
Diodes are a different version of TLDs.
Oh, okay,
Oh.
well then, I go with B then.
Who would be? Okay?
Yeah, smart.
Wow, impressive.
TLDs measure absorbed dose and can be placed on the patient's skin and compared to calculated skin dose. So that is similar, it's a different method, but that's similar to diodes. Everybody uses diodes, everybody seen diodes?
so you wouldn't get, would you get an immediate reading?
Not with TLDs, with diodes you
Diodes you
would,
would,
but
so-
TLDs you have to either read them in-house or send them away. But usually with TLDs, you read them in-house and they're there for, in an hour or so, so.
So that's used more for planning purposes, and the diodes are used to monitor?
No, TLDs you can use for treatment, yeah. We used to put TLDs on the eyes because it was much easier than putting diodes on them, because the diodes are are little capsules, whereas the TLDs are flat. They're like little squares of white powder, like a centimetre square. And they're easier to put on eyes and testes and stuff like that, rather than diodes. Okay. Oh. I guess I have to minimize this, I'm sorry. Let's go back. Yeah, because I have to do this. Okay, so your patient is being treated to the oral cavity. Excuse me, your patient being treated to the oral cavity may complain of. So you have radioactive fillings, sore teeth, sore mouth and gums, or acid reflux. Which one?
See,
C? Everybody agree? Will likely experience dry mouth and mucositis causing the gums and inner lining of the oral cavity to be sore. A good surface landmark for the true vocal cords.
we did this one.
Yeah, but it was asked in another.
I know, but I'm just
another
trying to
way.
remember what we said. The answer.
This is where the thyroid cartilage came up.
Yeah, I think that's the
thyroid
answer.
notch.
That's what I was thinking.
Yeah,
Because I think we picked the wrong one, and then
We
that
did.
was the answer.
yeah.
Yeah.
So you have a cricoid cartilage, the suprasternal notch, the thyroid, sorry, the cricoid cartilage, suprasternal notch, thyroid cartilage is thyroid.
Thyroid, thyroid.
Thyroid cartilage. Okay. Yep. True vocal cords are located about a centimetre inferior to the thyroid notch. That's where the thyroid notch came up. Okay. Patient being treated for primary brain malignancy may be on medication to decrease intracranial pressure. This medication is called whatever.
Steroid.
Analgesic, antiemetic, steroid, or hormone.
Steroid.
Pardon?
Steroid.
Steroid. Which steroid in particular? Dexamethasone? Yeah. And what's its normal name? What do we actually normally call it? Dexamethasone is its correct name.
Excuse me.
Decadron. So if you hear either Decadron or dexamethasone, then normally you would hear Decadron, but it's dexamethasone, yeah. That is the correct name for it. Yeah. Okay, if a centimetre of bolus is applied to an area being treated with a 6 MV beam, the maximum dose point will be located at, so it's asking for Dmax, with a centimetre of bolus on the skin.
Bravo.
3 Bravo. Because,
You're bringing the dose up.
so the Dmax normally for 6 MV beam is what? 1.5, so you add a centimetre of bolus and you get 0.5. When treating the floor of mouth, a bite block may be used to, so it says move the palate away from the treatment field, move the palate into the treatment field, depress and move the tongue into the treatment field, or project and move the teeth away from the treatment field.
I feel like it's C, but I don't know.
C? Anybody agree with C?
You would wanna treat
See
the
Charlie?
tongue, right?
Okay?
Oh, shoot.
I knew
See,
you
that's why
don't-
y'all don't let me pick it.
In CT, they say that you're supposed to move the tongue out, keep the tongue out of the way with the bite.
Well, it
Yeah, but when you're
depends
treating
actually. It says when treating the floor of mouth, the palate may be spared by using a bite block
That's
to
why I
move the
thought-
palate up and away from the treatment fields. However, I have a problem with this one because 99 times out of 100, if you're treating floor of mouth, the tongue is involved. Clinically, the tongue is involved. So you put the bite block in to put the tongue into the treatment field. So that being said, it's still good. So you're actually correct with this one, depending on,
If we get this question on the registry, what would you
and
go
if you
with?
get that one on the registry, it would be the palate.
Huh? Oh yeah. Okay.
I feel like you can't really move the palate. It's like a freaking dog.
Open your
Yeah.
Yeah, it's
Yeah,
not
that's
like a
about it.
loose item
So
in your
it-
mouth that you can move.
I don't think a bite block's gonna move that palate.
What?
I don't think a bite block's gonna move that palate.
You can try. Yeah. Normally, the bite block will move the tongue. I think that's only
I'm ready to sleep.
the third one you guys have got wrong, which is not bad. Okay, dense metal accessories should be placed at a suitable distance from the patient's skin in order to prevent contamination from secondary what? And it says select two. So, electrons, neutrons, lead, and radon. Pick the two obvious ones, guys.
Electrons and neutrons.
Electrons and neutrons,
No, electrons.
that's wrong.
Secondary.
Okay, are we all agreed on electrons?
Yes.
Okay. So dense metal in patient's skin in order to prevent contamination from secondary. Would it be radon? No. Would it be lead? Secondary lead? So the only one left
Maybe. Who
It
knows?
is
is neutrons.
Maybe. Who knows?
Interaction from radiation beam and any dense accessory results in secondary radiation in the form of certain particles or low energy X-rays, depending on the modality and energy of the beam and the accessory material. If you have a high energy photon, it can produce secondary neutrons in the room. So that's, have you how high are your energies in your machine, in your treatment machines? For your photons, you have a 6 MV and what?
10.
10? Anybody else got higher than 10?
I think we had a 15 at.
No, is it 15
At Orange Park,
electron or
we had an
15
18.
photon? It's photon, 15. What else? Anybody higher than 15?
At Orange Park, there was 18.
There's 18, do they ever use it?
Like every once in a while,
And that's for photons.
I guess. I don't know.
This is usually 18 electron.
I've only ever seen them use
Yeah.
it like once
So
or twice.
with
I can't
anything
remember what it was for.
18 MV or higher, the radiation, the photons can produce secondary neutrons. And if you ever see them, if you ever see the therapist, once the machine goes off, waiting for about 15 or 20 seconds before they open the door, if you're using an 18 MV or higher, that's why they want the neutrons to dissipate. Just a piece of useless information. So,
It's useless.
Which of the following technologies can be used to replace the need for wedge filters? And I'm talking physical wedge filters. Is Sanford still using their physical wedges?
No.
No? Have they got rid of them?
Yeah.
Damn. You ask Fred next time you see him if they have a wedge filter kicking around and if they can donate it to the school, please. Thank you. Okay, so you have 3D planning, dynamic multi-leaf collimators, respiratory gating probes, or fiducial marker trackers. B as in Bravo. That's what we call, what do we call those? Dynamic wedges. Dynamic multi-leaf collimators can be programmed to move across the field and mimic the influence on the isodose distribution, just as with using the physical wedges. Okay. From Washington and Lever, this one right here, according to the dose volume histogram shown, the whole heart receives. Okay, let's see. Can everybody see that? So the whole heart is this. So this is the volume here. Let me just go back and just see here. The whole heart receives what? Okay.
Let me see, what are the options again?
Pardon?
I need to see the options again.
0, 250, 1,000, 1,400.
0.
0? Everybody agree with 0?
Yes.
Yeah.
Okay. Yeah. Did everybody see that on the histogram?
I'm confused, but
Okay.
that's normal for me.
Let me show you so basically reading one of
She just
those,
witnessed.
you.
The whole
No.
heart is
Let me
the triangle,
show you
right?
something.
Right?
Okay, so your heart, the heart is a little triangle, the black triangle.
Yeah.
So what you're looking at is you have a volume up here,
Yeah.
you have, oh, let me use my, so the volume is up here.
Oh my god.
So 100% would be the whole heart. And here's your diagram. Here's your little triangle. So this is your dose in centigrades. So,
Oh, so the whole
That- the
heart
whole
is
heart
100. And
gets
oh,
0.
okay.
Okay, so if you're looking for 10% of the heart,
Oh, okay.
you would get about 1,200 centigrade.
Gotcha.
Okay, so your tumor, your spinal cord, for example, is the round one. So 100% doesn't look like it. So 60% or 58% would receive about 500.
Okay.
That makes sense then. Okay, good. Okay, let's get rid of that. Okay. So, I guess I
I like it.
so Sorry?
I liked it that big.
I can't do it.
I know.
You can just bump
Sorry.
it one more, cause then you
One
can
more.
see the submit. If
Bump it
you,
up one more.
yeah, just
I
one.
can't because
You did,
I
you did
can't see
before.
the,
You can see the submit.
The
one more.
submit is one more.
Two that she.
it's the goal, it's this
Oh.
part. But I
Oh,
can't, I have to see.
Oh.
sheesh.
Go to the next one.
Yeah. So, yeah, that's that one. So, when setting up a patient, the table continues rising after the release of the enabler switch. The therapist should immediately do what?
Oh.
The bed is moving up.
Oh,
You release the enabler switch, it keeps moving.
Oh no.
Emergency
Yeah.
off.
Are you from saying bad
off
words?
button.
Delta.
So,
That's bad.
on most, yeah, it's very bad. On most machines, you have big red buttons. On all machines, you have big red buttons. But sometimes there's buttons on the table as well as being on the wall. The table ones should knock the power off just to the table.
I said
I
that
think you should
yesterday.
just
because I was going over my, are you doing that?
As it's moving up, Morgan.
And he says, he swears on his machine that it takes everything down.
Which type of machine does he have?
The variant,
The variant?
What?
The
21 IX.
21, no, it doesn't.
He was like, do not,
I
it's like
have-
I'm telling you, it takes the
yeah.
whole thing down, do not hit that, and I'm like.
Well, on every variant IX I've ever worked on, you hit that button and the table stops.
Where
It
was that
doesn't
button?
knock anything else. Mind you,
On the actual couch.
on the actual couch, on the stanchion of the couch.
Yeah, I don't remember.
You have two buttons, one on one
I've
side,
hit it on
just
Electa a
below,
ton of times.
or
so
actually
it's
just on the bar
the
where you have the movements.
couch.
I
There's a-
have
there's a button
accidentally
there.
hit it on the Electas.
Yeah.
in-
Yeah, we turn it off all the time
In
accidentally.
Jacksonville, yeah, and
Yeah.
you just have to.
Yeah,
Pull it out.
but, okay, go with what he says, but
Yeah, I'm not gonna. put it
I
in the
would
For
suggest
funsies?
that he is mistaken, shall I say. Because if it had been the newer versions, I would say, okay, they've
Well,
changed
he
it.
says that he has to test them at monthly or something like that, and he swears, so I don't know if maybe it's,
Next time, he's gonna test them,
see if I can be there.
ask if you can be there just to look, because it's a good learning experience anyway. But they may have, their physicists may have altered it to do that, but every IX that I've ever worked on, no, it doesn't. So anyway, you hit the big red button, okay?
Are we sure it's not A?
Pardon?
Are we sure that it's not A?
Just push them off.
Yeah, because you'd have to say push or pull,
Jump, 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 jump.
yank.
Yank.
We're going for a
You know,
ride.
she's gonna fucking fail me just
If any
because.
motors continue to operate after the release of the enabler, the patient is on, and the patient is on the table, the therapist should quickly hit the emergency off. So, that gives me a chance to ask, if you hit the big red button and the machine stops, everything stops, the machine comes down with a, you can hear a sort of boom crash. What do you do next?
Shit.
Literally shit, probably.
Are you talking about just the couch, stopping the couch?
Pardon?
Or hitting the big button on the wall?
If you're sure that the buttons on the couch will stop the motion, then hit the buttons on the couch. If you're not sure, you hit the big red button.
So you're saying after you hit the button on the couch, what do you do? That's what was your question.
Well, let's say you're hitting the big red button that stops everything. You're not sure whether the couch one knocks everything down, so let's stay with the one that knocks everything off.
Well, you have to get the patient down safely.
You have to get the patient down safely. How would you go about doing that?
You'd probably want to get assistance.
There
obviously. Yeah, as soon as everybody hear the machine going down, you'll have lots of assistance, I can assure you. So, if the patient is mobile, like a walking, talking type person, and they're mobile enough to come down from that height, depending on the height. How high is your little footstools? They're not high at all, they're about this size, right?
Unless you're in
So
Gainesville.
if your patient's way up high, they're not gonna give you a lot of good anyway.
So
So
on the
with
hexapod table is so tall.
the variant
Big
machines,
fucking
you
stuff
have an emergency pendant. And the emergency pendant will only work if the power is out. Once
Oh,
you-
that's convenient.
Yeah. So the emergency pendant is usually in the stanchion behind the gantry. You open the door. Has anybody done warm up yet
Yeah.
on the machines? On the variant machines, you have doors that open both sides of the gantry. So you open these doors, that's where you see the water level and the gas level and stuff like that. So you'll see the square little box about this size by about this size. And it's corded, so it's actually attached. You take it out of its cradle and there's a button at the top. And there's a dial in the front. So you can either do out or down. So you switch it to down, you hit the button at the top, and the bed goes very slowly down. If that fails, you have a hand crank.
I was gonna say, is there a manual way?
Yeah, there's a hand crank that is on the very front of if you're looking at the bed this way, the gantry's ahead of you. If you look down almost to the floor level, you'll see a hole on the bed. And that's where the hand crank goes. And you basically put it in and you turn it. It blazes and the bed comes all the way down. Now, I think there's a hand crank on the Electa, but I'm not sure about I don't think there's an emergency pendant. So you might want to check on that for us.
Have any of y'all had to do that?
I've seen
I've had to do that several times on a variant.
Oh,
Yeah.
I want to tell you about my patient.
Oh Lord, yes.
Hold on.
Bed down and get the lady off or the patient off. What's next? So you take them outside and tell them, have a seat for a minute, we'll get the machine checked. So, what would you do? What's the next thing that you have to do? Your machine is totally down.
Well, you're gonna have to restart the
Remember,
machine.
you normally don't turn these machines off, you turn them to standby, so there's always power going through them. At this point in time, you have no power whatsoever. What do you do? How do you turn power back on? Pardon?
Circuit breaker?
The circuit breaker. There's usually a breaker beside the door of the machine. So you turn the breaker on, and sometimes you have to push a button and turn the breaker on. And because the breaker isn't used that often, it's sometimes very stiff. So sometimes you need two people to actually push the breaker on. And then you would bring the machine up as you would normally do for first thing in the morning to do the checks. Then what would you do? So you've got the machine powered up, it's warming up. How long does it take to warm up? When you come in the morning and you turn the key to switch it from standby to on, how long does it take before you can actually start running beams?
It's 12 minutes in Jacksonville.
12 minutes, 15 minutes, depending on the machine. So then you wait for it to warm up. Then what do? What do you do then?
Run through all the energies.
You do a warm-up. Normally what you would do is, if you have no electrons for the rest of the day, say it went down at 2 o'clock in the afternoon and all you've got is photons for the rest of the day, then all you would do is run through your photon beams. If you weren't using electrons, then you wouldn't have to do that. Obviously, in first thing in the morning, you do them all, but because you're bringing the machine up from cold, and then you would get the physicist or engineer, whoever looks after your machines, to come and check it, make sure everything's good before you start again. Okay, so next. Okay, patient is treated isocentrically with opposing fields on 80 centimeters SAD, 4 MV electron, or excuse me, 4 MV linear accelerator. The original setup was for mid-plane treatment at a depth of 10. You recheck SSDs and note that the SSD for field 1 is 70 and the SSD for field 2 is 72. What is the new patient separation?
Yeah.
It was written slightly differently, yeah. So what's the new separation? Come on guys, it's not that difficult. So your AB depth, the SSD is 70. And your 80 centimeters SAD, so what's your depth from AP? Come on. 10, ring a bell?
So it's 18 because you've taken off the 2?
Pardon?
Is the answer B?
So it's 18, the separation. And it should be the depth, the mid-plane treatment depth should be 10, which means the separation was 20. So what, if you want to do it mid-plane, what would your AP depth be now? So if your separation is 18 and you want it mid-plane? 9, which is? For an 80 centimeter SAD, a depth of 9 would be what SSD?
So 71?
Guys, it's like pulling teeth.
It's hard in the morning.
Yeah, I know. So, separation. There you go. Okay. So, here we go. 80 centimeter 4 MV accelerator. Original setup was for, okay. Field size for number 1 is 70 and field for number 2 is 72. What's your new depth? Will you calculate the monitor units for? Mid-plane depth of 10. Again, 70 and 72. So what's your, so again, it's 18, right? But it's asking for the new mid-plane depth, which is?
A.
Huh?
A.
Thank you, I thought you said 8, I'm sorry. 8. A. Yeah. Okay, the use of dynamic multi-leaf collimation is an important component of non-coplanar treatment delivery, digital reconstruction of images, intensity modulated radiation therapy, and reverse treatment delivery.
C,
See?
that's my guess.
Yeah. Dynamic multi-leaf collimation, the collimators move during treatment. It's a component of IMRT, but it can be used with 3D. It's more commonly used for IMRT, but it can be used with 3D as well. Treatment of seminoma, an extended testicular shield, external testicular shield, should be used for the remaining testicle. This is important since the TD55 for testes is as low as. We had this same question last week, I think.
Yeah.
There must just be a random word bank or something.
Pardon?
There must just be like a random word bank that it pulls from, if it's pulling the same questions.
It's A.
So which one was it? A? Yeah. You are called to treat a spinal cord compression. The physician asks you to set a preliminary field to cover thoracic vertebra 3, 4, and 5 on the treatment table. The approximate field size would be 3, 4, and 5. What the heck?
They're doing CPR.
Pardon?
CPR.
Oh,
She keeps
CPR,
yelling him
okay.
or something. I'm like, what?
Yeah, they're doing CPR.
So, how thick, how long would you give a vertebra as far as distance goes? Would it be 2 centimeters or 2.5 centimeters or 4 centimeters, or what would it be?
I'm gonna say 2.
2 centimeters,
So it's
okay?
either A or B.
I'd go
So
with
you
A.
have 3, 4, and 5. So that would be 6 centimeters.
Yeah, but it's kind of close.
I think
It's a little
probably
extra.
B,
Yeah, I'm thinking B.
B, 8 by 8, okay,
Giving unwanted dose to healthy tissue.
yeah. Of course, it's not only the vertebra, it's the intervertebral discs as well, right? So, let's see what they say. Yeah. Thoracic vertebra are about 2.5 inches, 2.5 centimeters in length. So basically 3 times 2.5 is 7.5 to include the transverse processes. The width of the field would be an 8, so an 8 by 8. You probably wouldn't do any more than an 8 wide for a thoracic vertebra. For a lumbar vertebra, you may go to a 10 wide, and a little bit more for the length. Okay, one more and then we'll go for a break. We'll have a break. Field with an approximate size of 21 by 19, having 1 to 2 centimeter flash over the skull and having an inferior border at the base of skull describes the treatment for. So you have, for those of us at the back that can't see, brain metastasis, glioblastoma multiforme, medulloblastoma, or ependymoma.
A.
A?
Yep.
So we're describing brain the field for brain metastasis. Yeah. Okay, so we'll leave it there. Let's just take 15 minutes, guys. Last week, right, or week before last. This is basically a back pointer. So this is